Good afternoon and welcome to today's Internal Medicine Grand Round. There is no commercial support for today's program. The speaker and the planners have disclosed no relevant financial relationships with commercial interests. If you have a question for the presenter, please hold it until the end for the Q&A segment at the end of the talk. If you are attending virtually, please enter your question in the Q&A section. Also, a link for the SurveyMonkey will be shared at the end of the program. It is my pleasure to introduce today's speaker, Dr. Michael Sun. Dr. Sun was born in Hohhot, China, and raised in Lilburn, Georgia. He did his undergraduate degree at the University of Georgia and at Athens, Georgia, and attended medical school at the Philadelphia College of Osteopathic Medicine in Suwanee, Georgia. He will be starting a fellowship in pulmonary and critical care medicine this upcoming year at the University of Oklahoma in Oklahoma City. Outside of medicine, Dr. Sun's interests include keeping up with the latest television shows, global economy, and global warming. Please join me in welcoming Dr. Sun today.
All right, let's start off here. This is me, and this is the presentation today. We're going to be talking about overly just, is IV iron safe to kind of use when there's concern for increasing risk of infection? All right. No disclosures. These are our learning objectives. We'll briefly go through these. All right, start off question, okay? If you get a question right, please see me after. I have prizes for everybody, no actual money value. According to the Global Burden of Disease study in 2016, okay, what is the estimated worldwide prevalence of iron deficiency anemia? Any guesses? Hands raises. All right, please raise your hand. See, that is correct. All right, please see me after. So yes, the worldwide prevalence is about 1.24 billion in those with iron deficiency. There's huge variations from low to high income countries. In the US, about 10% of the adult population likely has iron deficiency anemia. When you go into the elderly population, it goes a little bit more to about 13% when your age approaches 60 or above. And then let's see this slide here. Very prevalent, 1.2 billion around the world. Similar to iron deficiency anemia, the use of IV iron has also really become widespread in the last few decades. This is in part due to multiple reasons. One is that many clinical guidelines are continuously recommending IV iron use. CKD with anemia, heart failure, post-op, and inflammatory bowel disease. Moreover, many patients chronically have issues with oral iron, poor absorption, necessitating a better alternative. OBGYN patients, often post-op bleeding, things like that have allowed for continuous growing use of intravenous iron. Safety has been ever more improving as well. Minimal transfusion reactions compared to prior, and overall new formulations are really great. In the 2013 to 17 Australian data we have here for dispensing, you can see that the overall prevalence use of intravenous iron, this includes iron polymaltose and ferric carboxymaltose, has just kind of rapidly increased over the last 4 years. So that's very kind of similar here as well. So the role of iron, iron is very important in our body, vital for energy production, O2 transport, DNA synthesis, kind of everything that keeps you alive. When you don't have enough iron, cells tend to die off, and you have issues there. When you have too much, free radicals form, and that can also be in turn an issue. That's a picture of the electron transport chain. All right. Question, similarly, hemoglobin can carry and transport O2 via bound iron molecules. What element forms the O2 binding domain of hemocyanins, which can help deliver O2 in certain invertebrate animals?
I got the mic. Who's answering? Hand. Okay, we're gonna say B.
Oh, what did you say?
B. Copper.
That's right. Dr. Newcomb, please see me after the presentation. So copper, yeah, that is correct. Hemocyanins are also O2 transport proteins. Interestingly enough, in some invertebrates, like the octopus vulgaris, that was the first discovered, and now also in the emperor scorpion. How about that, huh? Okay, so here we'll go a little bit about iron absorption. So we get dietary iron via our enterocytes. Once it's absorbed, it's then transported out the gut bacteria via ferroportin as transferrin, which is the main transporting protein. Then it's stored in your liver via macrophages or goes to where it's needed for erythropoiesis. The large main regulation of this is via hepcidin, which we'll later discuss. Nutritional immunity is one reason for the thought behind does IV iron worsen, increase your risk of infections. The thought is iron regulated by hepcidin, it functions by inhibiting ferroportin and kind of decreases the amount of iron circulating in your body. During times of infection, inflammation, or even when you're getting iron, your hepcidin increases, kind of keeps ferritin trapped into cells away from where bacteria can get to it, and that's kind of termed nutritional immunity. Other than that, we should be good here. Here's a picture of normal deal. This is normally enterocytes, we already discussed this, absorbs iron, gets into ferroportin, transfer into where it's needed, bones, hematopoiesis, et cetera. Iron deficiency, you have decreased iron, so everything's kind of functioning as the same, but reduced, decreased erythropoiesis. Here, iron is normal, but we have functional iron deficiency with upregulation of hepcidin. When this happens, less transport out of your gut enterocytes, less transport out of your macrophages, similarly less red blood cells, or just overall erythropoiesis. Oh, here's another question. Can somebody read this question? Yakut.
A 36-year-old woman is evaluated for fatigue of 3-month duration and dyspnea on exertion of 1-month duration. She is 1 month postpartum. She takes no medication. On physical examination, vital signs are normal. Pallor is noted. No scleral icterus is seen. The remainder of examination is normal. Lab studies show hemoglobin of 7.9, white cells of 6.8, MCV of 70, platelet count of 414,000, RDW is elevated. Peripheral smear shows microcytosis and anisopoikilocytosis, but no other abnormalities. Which of the following is the most appropriate treatment? A, colonoscopy. B, oral iron every other day. C, oral iron 3 times daily. D, hemoglobin electrophoresis.
What's the answer, Yakut? Oh, Dr. Barker.
B.
Excellent. So the reason behind that, the thought on kind of what we discussed earlier was the upregulation of hepcidin largely decreases erythropoiesis, which is our ultimate goal. IV iron itself increases hepcidin and kind of functions with that. More questions. What's the first common syndrome that involves, Dr. Barker, please see me after the presentation. I have rewards for everybody. Iron deficiency anemia plus esophageal webs / dysphagia. What's that called, people? Who said it first?
Plummer Vincent.
Wow, congratulations, sir. Number 2, iron deficiency anemia, aortic stenosis, and GI bleeding.
Haley syndrome.
Dr. Strike, did you say that first? We'll give it to Dr. Kilroy. Okay, all right. Please see me after. Correct, you're both correct. Very good job. All right, so iron deficiency, here are some of the recommended guideline thresholds. Generally, ferritin less than 15 kind of dictates absolute iron deficiency. However, many people use a threshold above that, still has a very high sensitivity and a high specificity as well. Concomitant inflammatory conditions, some recommend using a low TSAT, 16 to 20% with inflammation, can be used for a higher ferritin threshold such as 100. So if your ferritin is like 100, it's not necessarily less than 50, but if the iron TSAT is super low, then you think, okay, maybe still. That one's a little bit more iffy and kind of in the air, but that's about that. Ferritin in heart failure, recommended you get IV iron if it's less than 100, or if it's between like 100 to 200, and then your TSAT's less than 20. And then many of you already know this, but we'll just briefly go over it. In people requiring dialysis with CKD, recommended is ferritin less than 500 or TSAT less than 30. If you're non-HD, less than 100 ferritin, or TSAT less than 40, or a ferritin less than 200 or TSAT less than 25. So going through this, I'm trying to find evidence on what there is saying that intravenous iron increases the risk of infection. Across many randomized controlled trials previously done, this was one that I came on from Norway recently in 2018 by Randy et al. All right, so they looked at the association of iron status with the risk of bloodstream infections and mortality. They initially got preliminary iron labs, iron saturation, TIBC, TSAT, all the usual in about 60,000 patients, 61,000. And the incident of bloodstream infections were kind of measured prospectively. Findings, they found that about 1,700 individuals experienced at least one episode of bloodstream infections, and 370 died within 30 days after that infection. Bloodstream infection risk was definitely increased in patients with iron deficiency itself, and that's defined by iron of less than 2.5 percentile. You can read that, TSAT less than 2.5 percentile, or TIBC greater than 97.5 percentile. And the association similar or after adjusting for comorbidities. However, there was really no significance of them measuring with intravenous iron received, and thus they couldn't find anything on how much it impacted the rate of infection itself. Some limitations, similar studies in the past have shown associations between high iron biomarkers and the risk of sepsis, and this was an observational study alone. Looking through some other ones, these were just 3 past ones done as well in non-CKD, non-dialysis dependent CKD populations, with 2014 being the most recent one. Of note, all of these were included in a meta-analysis we will discuss here in a little bit. The largest one you can see here is the last one with McDougall. In 2014, data on this one was similar to previous mixed kind of evidence. No specific recommendation for or against IV iron causing serious infection. Here's another ongoing one. It's in Tanzania. They're looking at women post-childbirth, all requiring IV iron due to iron deficiency. They gave them oral iron, IV iron. Similar improvement rates in their iron deficiency anemia. However, the IV iron took a few days to kind of give it, and then the oral iron multiple weeks. Improvement was about the same. Only 2 mild, moderate infusion-related events, 5 serious events. However, the authors did note that none of these were related to the study medication. They didn't go further into it, but that was that. These are some of the previous meta-analysis done. These were on prior CKD patients as well, spanning from 2013 to 2019. Let's look at the evidence surrounding this. The largest of which was performed by Lytton in 2013. It showed a 33% increased risk for all-cause infections following IV iron. However, 3 smaller meta-analysis with narrower scope indicated no association or even reduced perioperative infections in IV iron use for orthopedic surgery patients. So as you can see, it's kind of very mixed. This is the one that I was talking about earlier. This is the most recent meta-analysis I could find, 2021 by JAMA. They did a pretty big one. All the previous randomized control trials we kind of talked about, results were kind of included into this one as well, so take note of that. Their objective kind of to see what is the risk of developing new infection with intravenous iron compared with oral iron or no iron. And interestingly, they clumped the oral iron or no iron together, so there's no direct comparison between intravenous iron to oral iron or intravenous iron to no iron itself. Over, let's see, 154 randomized controlled trials were included, 32,000 participants, went from multiple studies dating all the way back to 1966. Primary outcome was the risk of infection. This was kind of a little bit mixed matched as well. You know, in the past, a lot of randomized controlled trials have varying definitions of what an infection is. Is it, you know, sepsis? Is it urinary pneumonia? So I think this is part of one of their difficulties of defining an infection, which we'll later talk about. Secondary outcomes, mortality, length of stay, and the changes in hemoglobin, obviously, and the need for transfusion. So of the 154 RCTs were included in a comparison between IV iron to you know, no iron or oral iron. IV iron, they found, was associated with increased risk of infection. The number needed they harm was 62. So in absolute terms, for every 1,000 patient population treated, they think 62 patients may develop an infection when treated with IV iron. And again, urinary and pulmonary infections were the most common, but the definitions of cross-reporting was very here and there. IV iron had a mean improvement hemoglobin of 0.57. This was smaller. There was a smaller change in red blood cell units transfused compared to IV iron. So there's a little bit of benefit there, but however, there was no evidence of effect on mortality or hospital length of stay, which is kind of what you're really looking at in the end there. When regarding limitations to this study, I think the main thing that we kind of discussed was, you know, you can only do so much with what you're given. If everybody prior to this had different definitions of infections, it's hard to draw out good data from that you can actually interpret well. In addition, previous studies, they did not define if there was a worsening of infection. Was it a new developed infection, which sometimes can, you know, play the case. Sure, you know, you may not think about giving IV iron to an iron deficiency patient, you know, when they're in septic shock. But, you know, that doesn't necessarily mean if they have cellulitis, why not, you know, throw some IV on there before they go home in 2 days if they're symptomatic, especially that. I think the key takeaways, so the JAMA publishers only assigned a yellow recommendation, unclear benefits, uncertain with the evidence of harm, even they kind of felt that way as well. And there's, you know, possible limited evidence of improvement. In my opinion, the infection risk of IV iron is inconclusive at best. Once again, we kind of discussed how there was no comparison of oral iron to IV iron. by that interest, it's, you have to ask, are they assuming that oral iron by itself doesn't have any implications for worsening infection by itself? Possible, did we discuss this? However, the severity of the infections previously were not discussed. It's not impossible, that IV iron can worsen infection. The pathophysiology kind of aligns with it, but the evidence, I guess, quality isn't there, and it's not consistently there. For future research considerations, I think limit inconsistencies and variations in infection reporting that leads to further uncertainty. That can be very difficult. Smaller trials have done in the past, but a lot of these trials have ultimately had different outcomes and different results in the end. In addition, using more standardized definitions for infection. Is it a growing infection? Is it cellulitis, sepsis, bacteremia, bloodstream infection? Similar to, across board every other specialty by standardizing definitions, having, direct comparisons that you're able to track across multiple studies leads to better data that you can then compare in the end. And then possible focus on the interactions between specific pathogens and risk of developing new infection with IV iron, I think is another possible future consideration. Here are my final opinions. Like I've said, quality of evidence isn't really for or against IV iron increasing the risk of infection, and it's very weak. Always use your clinical judgment. Use IV iron if it's indicated. And here I have a final story to consider. One of you, or some of you may have already heard this before. On September 26, 1983, Colonel Stanislav Petrov faced an unimaginable force early morning. The Soviet early warning missile service detected what appeared to be a single intercontinental ballistic missile ready to strike Russia, as he was told that morning. A strike that, if was true, would demand immediate retaliation and thus possibly igniting World War III. Petrov stood at a crossroads. What should he do? Should he trust the system's report, launch a counterattack, and plunge the world into nuclear devastation? Or should he hesitate, question the data, and risk being wrong? He chose restraint that day. When later asked why, his reasoning was simple yet profound. A true U.S. nuclear strike, he felt, would involve multiple warheads, not a single missile. His intuition prevented catastrophe that day. I can't help parallel his story in this moment to our current situation with the consideration of IV iron increasing the risk of infection. Do we have sufficient data to change our current practices? Or do we rely on clinical judgment, making decisions case by case, patient by patient? That is a question only you can answer. Thank you.
Hey, great presentation, man. Love you. I could have been in residency with you. Number one, the iron deficiency anemia, it's also going up in the United States due to bariatric surgery, more and more. So you're seeing it at this point in time. The other thing that confuses me is sometimes we check for one thing, but we miss another. We sometimes overlook copper, which is part of the binding. So we give iron, but no copper. The other thing is for heart failure, not only can you look at iron, you also got to look at other things because a lot of people just home in one thing and that's it. They overlook everything else. The other one is thiamine. So you got to look at B vitamin complex more than anything else for heart failure. And number one, which was shown in China, is beautiful, selenium. Selenium is necessary for heart failure because they study a province over there in China. It was, I don't know, whole province, whatever. And the majority of people had cardiomegaly. And it happens to be that they were thinking, what's causing this? They started looking at the soil, and the soil was completely deprived, and their meals were completely deprived of selenium. As soon as I started giving them selenium, the ones that were not terminally ill recuperated. So selenium is very important. And how do you get it? Great toenail, you clip it, you crunch it up, and then you see how many grams or milligrams of selenium there is more than anything else. So
Wow, that was very interesting. Definitely, that's a lot of information, some of which I knew, but a lot of I didn't. So I really appreciate you sharing that information with us today. I'm from China, and you mentioned China earlier, so I draw a close memory of home when you said that, so I appreciate that as well. Thank you very much for your comments today.
the other thing I forgot, because a lot of medicine today, we got two hands, we just use the right hand, we forgot the left hand. In other words, if you're gonna give selenium, you better give it with vitamin E. There are 8 types, vitamin E, tocopherol, in about 400 units. Otherwise, the selenium not getting in the mitochondria, it's not that good. So you gotta give it selenium with vitamin E, by the way, folks, just in case.
I have selenium in my shampoo, and they told me that was for dandruff. Does that get absorbed as well?
Unless you get a bottle of shampoo, put some tequila in it and drink it, no, it won't. See, people can understand that everything works from the inside out. Nothing works from the outside in. Sorry. Psoriasis and dandruff and all that more or less is skin. And we can talk about that later on.
Thank you very much.
When you read texts about iron supplementation for iron deficiency anemia, there are also some recommendations about supplementing with vitamin C to help iron absorption. What were your thoughts on that? Because I've read conflicting data on that.
I've heard conflicting data on that as well. I've seen things that recommended for it in the past, but I didn't feel like the evidence was really strong. I've spoken to some hematologists about it in the past as well. Some of them are for it with the thought of it can't hurt, why not try it? Others with the thought of, if it's not really proven, why do it anyways? So I can see, similar to various other fields of these two kind of trains of thoughts. If it doesn't hurt, why not do it? But then, if you continue with that thought, then you can just add 100 different things on afterwards and say, these 100 things probably don't hurt. Why don't you try them? But you spend your whole day doing these things, and then if there's no benefit, the effect is compounded by that as well. So I think that's how I feel.
Thank you, Dr. Sung, for a wonderful, engaging, interactive presentation today.
All right. Thank you.